You may have seen people walking down the street talking to themselves, not aware that everyone else can hear them. They may be talking loudly about politics or religion or the government, but not in a way that makes sense. They are disheveled. They may be pushing a shopping cart. They may be wearing a coat in the middle of summer. They might come up to you, or they may try to avoid you. Some of these individuals live with a chronic psychotic disorder. They may be stabilized at their baseline or functioning as well as possible given their history. They may be refusing treatment. It takes people on average a year to seek treatment when they first start hearing voices or having bizarre perceptions. What do you think keeps them from getting help? Would you want to let somebody know that you had been hearing voices? Oh yeah, by the way, I started hearing somebody talking to me this morning and there was nobody there. What do you think's going on with me? You may have heard the old expression, time is brain. To me, this means time spent staying on medication helps to protect the brain. Every time a patient goes off their meds, they risk relapse and they have an increased chance of decreased functioning. Welcome to part 2 of the Psychotic Disorders lecture. Here I have listed some common goals for patients with schizophrenia. In the inpatient setting, we focus first on safety. A goal in this situation might be, patient will not harm self or others during hospitalization. Your textbook will often mention patients improving their use of coping skills. That might be hard to measure. I might state something like, will verbalize needs without angry outbursts for 3 days. We might also encourage socialization and create a goal for them to spend a specific amount of time out of their room each day. Staff work collaboratively to stabilize and keep the patient safe during their acute stage of the patient's illness. I described in the Introduction to Psych lecture the different things we do to make the unit safe ahead of time and how we teach staff to be therapeutic. The most important thing we do is to get the patient started on an antipsychotic. While we wait for that med to start to take effect, which can take from 3 to 7 days, we start to build trust and rapport. Nurses often know the patients from previous admissions. This usually helps with reestablishing trust. Many psychiatric hospitals promote a culture of safety. One measure to accomplish this includes training staff in nonviolent crisis intervention techniques. In addition, hospitals have staff create their own personal safety plans. Each facility has its own type of response team for addressing patient behaviors which are a danger to the patient or others. Some hospitals use security in these situations, and in other hospitals, a group of staff members respond. In some hospitals, staff with behavioral health experience will respond to medical unit crises. I recommend that you identify what type of response is used in the unit where you plan to work and learn how to activate it to get help before seeing a volatile patient on your own. According to the APNA, there's evidence stating these 3 strategies can be effective at decreasing episodes of seclusion and restraint. Presence on the unit, a unit culture of calmness, structure, and collaboration, and assessing and intervening early with less restrictive measures. Another strategy is to use evidence-based assessment tools. In psych, we get to know all the patients on the unit. The person we have the most concern about each shift is one who has made threats or acted aggressively in the last 24 hours. We also use the Avert Agitation Severity Scale in several facilities, which you will use for your case study. Additionally, patients are screened for a history of violence on admission. How do we put all this together? We first pay attention to any recent threats made on the unit. We continuously monitor for symptoms of agitation or escalation and maintain awareness of the patient's triggers and safety plan. Patients with schizophrenia have been most stigmatized, and they're stigmatized as being violent. In psych, I used to see restraints used much more frequently. In my most recent experience, I have observed that we could assist patients experiencing psychosis or chronic schizophrenia without needing to use restraints. Now we see evidence in the literature that supports this, and I've seen the tools used above to help us to reduce this use of restraints. Now we're going to check in with our case study patient. Pause the video to read the information. Answer these questions on your activity sheet. We will review them in the Zoom portion of class. Another part of collaborative care is the delivery of antipsychotic medication. Remember, when a person is experiencing psychosis, especially if it is caused by schizophrenia, it's because they have too much dopamine activated. Their dopamine levels are too high. These medications decrease the amount of available dopamine and help the patient to start thinking more clearly. Some clear within 2 to 3 days, others are much better within a week. Others have more trouble. The more times they relapse, the more difficulty they have. What can we do as nurses to help decrease an individual patient's risk of metabolic syndrome? We can learn what meds carry the highest risk of causing this. We can see if labs were done, like blood sugar and lipid levels. We can check the patient's weight and abdominal girth. Be sure to Google that. I usually demonstrate it in class. We can also talk to patients about lifestyle factors. Maybe we can help them identify some healthy food choices that they might prefer to start to include in their diet. Perhaps also there's a type of exercise they enjoy that they would like to start to add to their activities. The other lifestyle factor or preference that they might have that we might want to address could be smoking. This might be a more challenging behavior to motivate patients to change. And then finally, remember, our patients start out with full cognitive capacity. That's a good time to get them to work on making some of these changes. Our approaches to the therapeutic relationship are different with patients with schizophrenia. Remember, they do not trust us. Competent, experienced psych nurses and techs develop very trusting relationships with patients. Here are a few of the skills they use. First, they don't crowd the patient. They give them space. They seem to be very mindful of the patient's boundaries. Next, they give the patient time to talk. If the patient walks away, the patient is probably extremely uncomfortable. We continue to monitor the patient from a distance, however, and periodically check back in with them. You may just acknowledge the patient with brief eye contact on the next check. Then work up to a few words the next time, like, "How are you doing?" Use short, simple phrases, 3 to 6 words. Use their name. Don't promise what you can't give. Don't say you can watch TV all night. The night shift nurse may not let them do that. Don't touch the patient. Patients watch us and can see if we are uncomfortable, so we want to be mindful of our body language. How do we build rapport with a patient with schizophrenia and/or psychosis?
If they have nothing to say, we focus more on communicating acceptance and being present. Just sitting nearby and checking in with the patient lets the patient know you are thinking about them in a non-stigmatized way. Listen for and take advantage of opportunities to respond to feelings. Patients often describe hearing voices that keep saying bad things about them. I might reflect that this sounds hurtful. How do you think the man with the car felt? I would guess that he felt scared. I think the biggest challenge when working with someone with psychosis is understanding and having the courage to intervene. Just how do we intervene when individuals are experiencing hallucinations? The most important thing to do when talking with someone who is actively psychotic is what is starred here. We want to state, I don't hear the voice of your brother, but I believe you hear him. Let's go over here and play cards. Notice that on the slide it says to do two contradictory things, reduce stimulation and reduce isolation. For someone with psychomotor agitation, I would reduce stimulation. Most people with acute hallucinations or in the acute phase need reduced stimulation. For someone with psychomotor retardation or with negative symptoms, I might reduce isolation.
After you've communicated your reality testing statement, you can check in about how the patient feels. Are they frightened, threatened? To distract them from their focus on what is not real, we talk about real, everyday things. It's challenging to focus on the here and now. At the VA, we talked about what they did in the war when they served, and then we played games. You can also talk to them about what they did or worked on in group. As you build rapport, you'll find topics to use for discussion. With one young man, I learned that he had played football, and I talked with him about that. I also learned that he had a job, and so that's something else I talked with him about. I'll talk with them about what they ate for breakfast, or something about where they've lived if I've learned that in conversation. Here are some interventions that you can try for people, but I would try these once the person has stabilized. Have them practice starting to check for where the sound has come from. Have them start to practice checking in with others to see how they're responding to the situation. Have them start to think about who they can trust when these issues start up for them.
Here are some additional interventions you can try. These are for patients who have stabilized. Have them practice checking for where the sound came from. Have them check to see how others are responding. Are they others hearing the voices too? Have them think about who they can trust. We approach patients' delusions with two strategies. We don't feed into them and we use distraction. Handling a patient's delusions is a challenge. Remember that a delusion is a fixed, permanent false belief. We want to find an opportunity to present reality without confronting the patient. We worked with a patient who thought he had a blood disorder and that he must lay flat at all times to prevent any further destruction of his blood cells. His lab work did not show any abnormalities in the CBC. We tried to cast doubt on the situation with this patient. I asked what his blood work showed. He stated the hospital had not completed the test correctly. The student tried redirection next. She asked about his breakfast. This was the only strategy that shifted his focus away from the topic of his false belief.
When we're trying to communicate with people with disorganized speech, we face two challenges. We struggle both to understand them and to get messages through to them. One day I sat with two patients. One was watching the other read the paper. It looked like he wanted to read the paper, so I asked, and I wasn't sure though what he said in response. I gave him the paper, he looked at it briefly, and then he set it down very abruptly. I waited a few minutes and then I said, was it hard to read the paper? And that really made him upset. So I waited silently, and then I said, it must be hard not to be able to tell people what you want to say. His eyes got really big, and I think that I kind of touched then on what was going on with him. At least I connected with the fact that he couldn't communicate. In another situation, I observed the rec therapist include someone in a game just through use of simple cues. Each time it was a patient's turn, the therapist would wait briefly to see if the patient would start to play. Then if he didn't, he would say the patient's name and give the patient one cue. And he would walk the patient through each of his turns that way. The therapist helped the patient to feel included and feel successful, and the other patients felt really good too, I noticed. I think they felt like, hey, if this happened to me, if I started functioning this way, I know that this therapist would take really good care of me.
When patients have disorganized thought processes, we need to make sure their basic needs are met. Our two biggest concerns are hygiene and adequate nutrition. Some absolutely refuse to bathe. Others just need reminders to shower or brush their teeth. We have individuals who may not eat and risk dehydration or malnutrition because they're afraid or paranoid about what's happened to their food. One community mental health patient was found unconscious and admitted to the ICU, where she remained in a coma for several days, apparently due to not eating or drinking adequately. They had found 30 empty 1-liter bottles of soda in her apartment. If we have found someone with suspicions about their food or drink, we try bringing them packaged food, which they will sometimes eat when they won't eat anything else.
Here's our case study again. Go ahead and pause the video so you can read through it. Now pause again and answer these questions. We'll review them in the Zoom session that corresponds with this class.
I have been describing interventions predominantly offered in Western cultures. These interventions may not be affordable in other countries. While patients in our country might have access to group therapy, case management, and follow-up care, these interventions are not provided in most middle-income or low-income countries. These countries also use medications which are likely to have more side effects. They use the first-generation antipsychotics, which are effective and less expensive, but also have a higher risk of causing extrapyramidal side effects, a set of movement problems you will learn about in the psychopharmacology lecture.
Here's our case study again. We'll review this information in the online Zoom session. You don't need to pause this time.
When we work with people with disorganized thought processes, we anticipate seeing them use inappropriate behaviors. What I try to remember is that they don't have that voice from the frontal lobe saying, hey, that's not a good idea to say something like that, or don't take your clothes off in front of everyone. Remember, in their reality, something else is going on. They are seeing the room and situation differently. As a nurse who has been in those situations, what have I observed? People making inappropriate statements, sometimes of a sexual nature, patients touching others inappropriately, people getting in each other's space. I will describe a situation in the next slide in which a 17-year-old tried to start acting like staff on the unit.
So how do we respond to these behaviors? Our goal is, again, safety first. We might want to educate the patient, but if the patient is highly agitated or acutely psychotic, we just need to make sure that other patients are safe and redirect the patient. If the patient is speaking rationally, we can set limits with the patient. So I had a situation, it was actually the situation I just talked about, and now I remember what happened. It was actually the little kids who were trying to do something with the TV. They were 7. This kid that I was talking about was 16. He weighed about 200 pounds. He tried to redirect the kids. So what I said to him was, I said his name, and I said, I need for you to let the staff handle this. And he said, it's going to take somebody a lot bigger than you to tell me what to do. And I was all I could do not to laugh, because he was totally right? But he did back off, and he was rational about it, but I couldn't have him intervening with those kids. I mean, he could have hurt the kids. So the limit setting worked with him. He was rational enough to make a statement like that, and that worked. So in summary, if the patient speaks logically, set limits. If they're acutely psychotic, use distraction and calm redirection.
Pause the video now and think about how you would respond in this situation. You will want to base your response on how well you know the patient, whether or not you have rapport with the patient, what backup you have available for safety on your unit, if the patient is in immediate danger, and how the patient responds to logic. I observed the staff member respond here. He was a charge nurse and knew the unit staff and the patients. He simply placed a gown in front of the patient, then calmly coached the patient back to his assigned room. The patient responded without becoming distressed. Now we are back to our original case study patient. Pause the video and read this update on the patient's condition. Here are the questions to answer in follow-up to how the patient is doing today. I encourage you to stop the video and try to answer the questions now while you remember what you've heard so far about psychotic disorders and schizophrenia. What thoughts do you think the patient might be experiencing after hearing about his diagnosis? All members of the team become involved in discharge planning. Important information for the nurse to communicate includes patient's medication adherence, the nurse's assessment of the patient's ability to remember to take their medication, and whether or not they understand the dosage of the medication and the importance of getting the prescription filled. The patient's overall functioning and self-care skills. Will the patient be able to manage their own money? Will they be able to understand how to use available transportation? The nurse is going to be able to provide input about this. The whole team will want to weigh in on whether or not the patient and family understand how to handle the next crisis, and they'll want to work together to help them create crisis and relapse prevention plans. We want to make sure that we include the family during the discharge process and throughout the patient's stay. Family members are more likely to still be involved at the time of a first break. Once a person turns 18, family members need to have legal designation to make decisions for patients. Legal issues related to care that arise are usually referred to case managers who determine who has the power of attorney or who is the legal guardian for the patient. A patient with schizophrenia will handle life better if family members stay connected. We want to help those family members and significant others learn why adherence is important and help them to identify resources. What do we want to teach the patient and family? We want to make sure they understand how the disease progresses, what changes could occur. And then again, we can always reinforce the need to adhere to meds, as I stated before. In addition, we would want to review the medications, making sure that they understand the anticipated benefits and significant side effects to report, like the high fever of neuroleptic malignant syndrome, which you'll learn about in Psychofarm, and what symptoms indicate possible EPS, which you will also learn about in Psychofarm. I would make sure to review resources, offer crisis prevention plans and relapse prevention plans as well. What resources are available? The Florida Assertive Community Treatment or FACT team assists with housing, medical care, and case management. They teach people skills like how to ride the bus and manage their medications. The National Alliance for Mental Illness offers support to both patients and their family members. Nationally, the organization maintains a website, sponsors research, and helps people network. Locally, support groups are available. One program that provides valuable assistance is the Family to Family program. Services provided include teaching family members how to handle crisis situations, helping family members build up their confidence and long-term ability to care for themselves, and provide support for the person with mental illness with compassion. Providing information about mental health conditions and current treatments, that's provided on the website. Two practices that will help our patients and family members are relapse prevention and crisis prevention. Relapse simply means that we don't want the acute stage of the disease to come back. Crisis prevention means that if the patient starts to show early signs of losing control, a plan is in place to help the patient calm down. Our key steps in relapse prevention include helping the patient understand what can cause relapse, the warning signs of relapse, and how to prevent it. Just having a new diagnosis can cause relapse. Stress at work or from trying to communicate in relationships can be a trigger, as can going back to using alcohol or other substances. Warning signs are the same as those of schizophrenia, positive and negative symptoms. To prevent relapse, encourage patients to take their medications, keep all doctor and therapy appointments, recognize warning signs, attend any weekly support groups or family education sessions, and to get to a doctor as soon as the patient or family member suspects a relapse.
When a crisis prevention plan is created, the patient and family ideally will sit down with staff and work together. Warning signs a patient might place on the chart or on the plan could include pacing, raising their voice, talking loudly when no one else is there or even around other people. Triggers they might include people telling them what to do, loud noises, being called names, feeling threatened. What might calm them down? These things might include taking a walk, playing music, taking a shower. Who can help? This might be a friend or a family member, so we encourage them to put down names. Maybe Steve or Bessie. These are just examples. We as staff members are going to collaborate with the family, and we'll help them come up with the names to put down of people that they can call and of the emergency contact numbers. Here's our final case study slide. You might want to pause the video and answer these questions now while the information is still on your mind. Again, we'll discuss this during the Zoom presentation.
In conclusion, schizophrenia may last a lifetime, but we have many opportunities to help people adapt, to motivate them to adhere to treatment, to help them feel less frightened and less stigmatized. This takes not only the nurses who are, quote, good with the patients with psychosis, unquote. It takes all of us in every department in nursing and in the community to be mindful of the nonverbal messages we send to patients, to advocate for their treatment with safe medication, and to take those initial steps to build trust with the patients we are going to meet who have this disorder. Finally, don't forget to attend the live Zoom session for this class. We will be applying the information from the presentation then. Also, be sure to post any questions you have on the discussion board. See you soon.